Hello friends, today we are going to discuss about hepatopulmonary syndrome. The association of the chronic liver disease and the respiratory symptoms and hypoxia is well recognized. The four main pulmonary complications may occur in patients with the chronic liver disease. That is pneumonia, hepatic hydrothorax, hepatopulmonary syndrome, and the pulmonary portal hypertension. So hepatopulmonary syndrome is defined as disorder in which pulmonary oxygenation caused by intrapulmonary vasodilation and less commonly by the pleural and the pulmonary arteriovenous communication occurring in the clinical setting of portal hypertension. The clinical manifestation of the hepatopulmonary syndrome in patients with chronic liver disease primarily involve dyspnea and platypnea. Dyspnea is the most common respiratory complaint in patients with HPS, but it is non-specific. Its onset is insidious, usually occurring on exertion. Platypnea, which is the shortness of breath exacerbated by the sitting up and the improved by lying supine, is less sensitive but more specific finding in this patient. Hypoxemia with the exertion and at rest is common and it is exacerbated in the upright position, that is orthodoxy. There is no signs or hallmark of HPS on physical examination. However, tachypnea, polypnea, digital clubbing, and cyanosis in patient with hallmark of chronic liver disease, it suggests the presence of hepatopulmonary syndrome. Now about pathophysiology. Pathophysiology of hepatopulmonary syndrome is characterized by intrapulmonary vascular dilatation occurring in the pulmonary arterial circulation. The vascular abnormality consists of diffuse or localized abnormal dilated pulmonary capillaries and is less commonly pleural and the pulmonary arteriovenous communication, which results into the impaired oxygenation of oxygenation of venous blood as it passes through the pulmonary circulation. So it impairs the ventilation perfusion ratio and it may result in an anatomic and functional shunt resulting into the hypoxia. In patients with the advanced liver cirrhosis, this leads to the subtle increase in intrapulmonary blood shunting, which is more pronounced in the patient with the HPS. The consequent increase of shunting and VQ mismatch in the upright position is a cause of orthodoxy. The pathogenesis of intrapulmonary vascular dilatation is multifactorial. It occurs due to release of nitric oxide, which is potent vasodilator, plays a critical role in the development of HPS. The increased release of nitric oxide in the pulmonary circulation is related to the increased expression and the activity of two isoform of nitric oxide synthetase and endothelial nitric oxide synthetases and inducible nitric oxide synthetases. Meanwhile, bacterial translocation related endoxemia and pro-inflammatory response also contribute to accumulation of macrophages in the pulmonary macrovasculature. Endothelial activation of the fractalkine chemokine in the lung may favor adherence of monocyte in the pulmonary microcirculation. Monocyte express the inducible nitric oxide and produce heme oxygenase, leading to the increased carbon monoxide production, further enhancing vasodilation. Now for the diagnostic criteria of hepatopulmonary syndrome. Hypoxia with the pulmonary partial pressure of oxygen less than 80 mmHg and alveolar arterial oxygen gradient of more than 15 mmHg in ambient air or more than 20 mmHg in patient older than 65 years. Pulmonary vascular defect with positive finding on contrast enhanced echocardiography or abnormal uptake in the brain with radioactive lung perfusion scanning. Commonly in the presence of pulmonary hypertension and in particular hepatic portal hypertension with underlying cirrhosis, prehepatic and hepatic portal hypertension in patients without underlying cirrhosis, less commonly in the presence of acute liver disease and chronic hepatitis. About diagnosis in the presence of tachypnea, polypnea, digital clubbing, and on cyanosis in patient with the hallmark of chronic liver disease, hepatopulmonary syndrome should be suspected and investigated. Pulse oximetry is the screening tool for hepatopulmonary syndrome in adult patients, but not in pediatric patients. For a patient with the saturation of less than 96%, ABG analysis should be performed and PO2 lower than 80 mmHg and the alveolar arterial oxygen gradient of more than 15 mmHg, while breathing ambient air should lead to further investigation. For adults more than 65 years, the A gradient of more than 20 mmHg cutoff should be used. The use of contrast echocardiography to characterize HPS is recommended. Transesophageal contrast enhanced echocardiography can be performed to exclude definitively intracardiac shunt, albeit this technique is not devoid of risk. Then this microalbumin aggregate scan can be performed in the complementary tool uh, to quantify the degree of shunting in patient with severe hypoxemia and the coexistent intrinsic lung disease, and to assess prognosis in patient with HPS and very severe hypoxia. Neither contrast echocardiography nor MMS scan can definitely differentiate discrete AV communication from the diffuse precapillary and capillary dilatation and cardiac shunt. Pulmonary angiography should be performed only in patients with severe hypoxemia, poor response to administration of 100% oxygen, and in whom there is strong suspicion of AV communication that are amenable to embolism. Now about management, long-term oxygen therapy is recommended in patients with HPS and severe hypoxia. Nevertheless, there is no available data concerning effectiveness, tolerance, cost effectiveness, compliance, and effect on survival rate of this therapy. No recommendation can be proposed regarding the use of drug and placement of tips for the treatment of HPS. Patient with hepatopulmonary syndrome and PaO2 of less than 60 mmHg should be evaluated for liver transplant since it is the only treatment for HPS that has been proven to be effective to date. Since severe hypoxemia is associated with increased post-liver transplant mortality, an ABG analysis should be carried every 6 months in order to facilitate prioritization to liver transplantation. Thank you, guys.